Hi, I'm Dr. Margreet Wibbeling, midwife specialist and your host of the Birth and Baby show, brought to you by Sister Lillian Center and Sensitive Midwifery. We empower moms and midwives to have the best birthing and parenting experience through natural, physiological and intuitive care, resulting in birth and baby advice you can trust. Hi everyone, we are here with yet another episode and we've been working on a series called birth options, and I've been addressing all sorts of different options you can get for birth, whether it's like a home birth or a midwife-led birth or a birth in a hospital, a water birth, etc. But one thing that I feel we still need to address is when should you go to a midwife for your birth or when should you go to a doctor, and what is the difference really, and it's actually quite important that we are aware of that so that you land in the right place and make the right decision for where you go for your birth. And I've got a very special guest. He's Dr. Howard. He is an obstetrician and gynecologist, and we work together because we're very passionate about exactly that the woman will give birth on the right place with the right healthcare provider. So you're in for a treat. Hi, Dr. Howard.
Hi, Margaret, and thanks for the invite, and hi to all your listeners.
Yeah, thank you for joining us. So, Dr. Howard, I know you quite well, but the listeners don't. So maybe just tell us a little bit more about yourself and your background and the work you do as an obstetrician and gynecologist.
Yeah, so I'm a 50-something-year-old obstetrician and gynecologist, qualified many years ago in the UK, worked in the private sector in Cape Town before switching into the not-for-profit sector, where I ran a couple of huge programs in the sexual and reproductive health system, eventually branching off into entrepreneurship, partnering with my ex-colleagues at PPO-SEF to create a team maternity model called the Birthing Team, which is now defunct, has been discontinued for various reasons, but clearly the successor to the Birthing Team is what you and I are running, which is Network One Maternity. So yeah, long and short of where I've been and who I am.
Wonderful. In a nutshell, yes. So you've got lots of experience in and around the reproductive health space. Maybe for our listeners, what exactly is an obstetrician and what is a gynecologist, and why? What is the difference when you come for, you go to your gynae or you go to your midwife? Can you maybe elaborate that a little bit?
Okay, I think it's a useful question to address, particularly for the non-medical people. And I guess obstetrics always goes with gynecology. But basically, obstetrics is concerned with the care of the pregnant woman, whereas gynecology is everything else outside of pregnancy. But as you can imagine, it's a continuum. So the distinction is really a convenience one, because whatever might be happening in the gynecology space might affect what happens in the obstetric or maternity space. But in terms of specialization, we as clinicians look after both aspects. So in a way, that's why I'm saying that it is really a convenience distinction, but that's the main difference. And coming on to your second question, which was who goes to a midwife and who is a specialist. So obstetricians are trained first and foremost as medical practitioners. So we qualify as general physicians. And then you go for additional training, which lasts between 5 and 7 years after you've done your internship. And at the end of it, you have got quite a mixture of surgical skills and medical aspects of healthcare. So in a sense, the two disciplines of surgery and medicine come together in the specialty of obstetrics and gynecology. So you are actually a specialist, and being a specialist means that you sit at the top of the professional pyramid in the sexual and reproductive health domain, and therefore the most appropriate use of a specialist skills is for those patients who have seen a midwife and complications or needs that are beyond the scope of a midwife, who might even have seen a medical officer with a specialization in obstetrics, and also the problem might be beyond their scope, where you then need a specialist who combines the surgical and medical aspects of women's health. So really, when you think of the general population, the majority of ladies or pregnant women should be okay being looked after by a midwife, because pregnancy is not a disease. It is a condition that can develop problems or can develop complications that require intervention. So by far and large, maybe 60, maybe 65% of ladies just need supervision and social support. Then there'll be the next segment that requires the input of a medically qualified person. And this is a generalist, a family practitioner with an interest in maternity or obstetrics. And eventually, if it is beyond their scope, then those maybe 10-15%, they really require specialist input. So in a sense, that's the kind of pyramid that you're looking at. And I must add,
thank you for pointing that out. It's clear, yes.
Yeah, even though I've just concentrated on the maternity and biomedical aspects, in our approach, the psychosocial aspect is very important. So there are the allied professionals that are involved in supporting that core team of midwife, medical officer, and specialists. So you would have a sonographer, social worker, dietitian, physician, and with the complications, anesthetist and pediatrician. So that forms the whole picture of the domain, as it were.
Yes, great. So we're definitely going to be talking about our approach and what we're trying to bring as Network One Health. But I like just to take a step back with the distinction. I like that you point out what an obstetrician is. I think most women, they say always we go to our gynae, but now they might understand where obs and gynae come, and that's obstetrician is with a pregnancy, a pregnant woman, and gynae is all other women reproductive health related issues. But I go hand in hand too. That's very well explained. So if a woman decides she's falls pregnant now and she has the choice to go to a gynae because she's got medical aid, for example, or not, or she wants to pay, or she's just trying to navigate this world, are there things that she can know already before the time, I won't be able to go to a midwife because X, Y, and Z?
Yeah, absolutely. So I guess the way to think of it is to ask the question, is there a problem that might be affected by pregnancy or that might affect the experience and outcome of pregnancy? If the answer is yes to any of these two questions, then perhaps the client needs to be considered for a specialist. So let's start with the first. Is there a condition that can be made worse by pregnancy? So we can think of, let's say, to keep it simple, somebody who might have a heart condition. In pregnancy, by its very nature, your heart is working a little bit harder because it is catering now for not one, but two individuals. So typically, there's a bit more effort that your heart gets involved in. But if you have a heart that's already kind of working at borderline maximum capacity, getting pregnant might just tip it over where it decompensates and might begin to give you medical problems. And I think that thinking or rationale applies to many other conditions that are worsened by pregnancy. Then the other side of the coin is there a condition that might affect the course or outcomes of pregnancy? And in here, we are thinking of situations that might include serious complications like hypertensive problems of pregnancy. There's a certain class of high blood pressure that only appears in pregnancy, certainly after 20 weeks by definition. And in those clients who might have had a fairly normal first trimester, the appearance of this condition necessarily excludes them from continuing their care with a midwife. Another instance is maybe clients with multiple pregnancies, so twins or triplets, or complications thereof, that you know that just having that obstetric complication means the outcome of pregnancy might be worse than the average healthy clients. And other conditions like HIV and TB that require specialist input into the selection of therapeutic agents that you might use. So that would be the domain of the specialist. And specialists don't typically work alone. They would be in consultation with the primary caregiver, the midwife. So the midwife is always going to be involved. And in consultation with the specialists, she can then coordinate the inputs of other specialties, surgeons or physicians or whatever the case may be.
Yes, that's very well explained. So it's really, as you also said, it's on the top of the pyramid. So it's actually really where that highly specialized care is needed once a woman has been going through screening. And sometimes they know it before they fall pregnant already, like, hey, I will be a high risk because I've got a heart condition or any kind of medical condition. But so that is quite clear, I think. And also, I like that you put out how we work in a team and how we always work together. And that is also something I'm very passionate about, especially to grow the access of midwife-led care, that the low-risk woman can actually have access to midwives. Because at the moment in our environment, we see a lot of low-risk women actually landing up by highly specialized gynaes. What is your view on that?
So it's a highly nuanced area of discussion, in that when one thinks of it, you would have to start with the background of how our own industry in the private sector has developed. And yes, also the perceptions that have been encouraged by the practitioners themselves, which seems to be that the more intervention perhaps results in better outcomes. I think that's the underlying assumption that drives the behaviors of clients when they seek help, but also the behaviors of the practitioners when they intervene. So let me underline here that
Yes.
everyone means well. Okay. However, when we look at it objectively and we apply best principles and best practices, I think the situation, for instance, in the private sector is completely upside down. I think typically clients feel more reassured, and perhaps just as a function of availability of people who can give the service, they go to an obstetrician. So I can think of many small towns where there are no independent midwives. Your choice is between a public sector facility or a private doctor who may be an obstetrician or a GP. There is no middle ground. So that's something that's in the environment. But beyond the environment, there is then the client themselves and their perceptions, how we are perhaps socialized into consuming healthcare. And certainly the underlying assumption seems to be that the more specialized the care provider, the better the quality. It's a fallacy. It's a fallacy. I think also because specialists are geared towards more complicated cases, they are more likely to intervene, and perhaps given the nature of our remuneration framework, there is then an unhealthy incentive to perhaps even treat clients that are not in need of a specialist at the specialist level, which is with its own problems of high interventions, therefore higher costs, and perhaps adverse experience of care. So it snowballs into quite a few other consequences.
Yes, and it's obviously it's understandable for the average person out there that I would think you need to go to the most specialized person. But I think it's good to then differentiate that the most specialized, when it comes to natural birth and a non-interventive birth for a healthy pregnancy and birth, the most specialized person that you need to seek out then is a good midwife, because an obstetrician won't be the best specialist in natural birth, to be honest, right? Because you guys are more geared to dealing with complications and interventions. So if you need interventions, then yes, by all means, you want to go to your gynae. So it's important to just have that understanding that you actually need to separate the two. There's something like a low risk population, and when it becomes a high risk, and that's where it's so important for us to work and collaborate so well together. As a midwife, we are specialists in discerning and picking up when things divert from the norm to become a risky, and then we refer to the doctors. So that would be the ideal world, I would say, right?
Yeah, absolutely. And I think I did make a reference to the point that pregnancy is not a disease. And, the requirements of the pregnant client have got a heavy component of social and emotional support requirements.
Yes.
And I guess midwives, being specialists in the normal process, if perhaps more training, are better attuned to the emotional and social needs of the pregnant lady than an obstetrician who's trained in pressure cookers. So when you are trained as a specialist, you train in pressure cookers that are the referral hospitals, where, as it were, your brain is really conditioned for going in and saving the day. But
exactly.
the majority of clients do not need that perspective. And the nature of the tests that we do, particularly in maternity, in monitoring of the baby, they've got, they're like a double-edged sword, as it were. That there is a lot of value that you can derive from using the technology to monitor the baby, but the rate of false alarms is also quite high. And given the same situation, different disciplines will react differently in terms of their propensity or the likelihood to intervene. And I'm arguing that a specialist who's dealt with a lot of disasters and they've got a memory of when things have gone wrong are more likely to intervene with a lower threshold than a midwife whose approach might be, let's wait and see, let's use technology to confirm that we haven't reached the threshold for intervention and etc. But always here emphasizing that the midwife is dependent on that good working relationship with the obstetrician. And
exactly.
That interface between the midwife and the obstetrician or the backup doctor has to be intact, because things can change even for the client that you think everything is going well 1 minute. 45 seconds later, the situation might be completely different. So in that sense, I would summarize to say that for the majority of clients, they ain't these firefighting situations, particularly if your midwife is working within certain standards, understanding what the triggers are for referring clients, when they should panic, and so on and so forth, then it is quite safe for that 60-65% to be primarily under the care of a midwife. That would be our say.
Yeah, wonderful. It's so good to understand the context and for us as healthcare professionals to be aware of each other's strengths and weaknesses. It's not a weakness; it's just where we are what's more our default setting, as you explained. I think in our environment in South Africa, we are working. You and me are working on some sort of solution. You are very much a gynecologist, obstetrician that is pro-midwifery, and that's quite refreshing because at times as midwives we experience actually the opposite, and we're almost more in a fighting relationship. They're not trusting us midwives and so forth, and that doesn't benefit anyone, right? So maybe you want to explain a little bit your point of view and what we're busy trying to set up and build to change this.
Yeah, so thanks, Margaret, for the opportunity, and I guess we must acknowledge here that we're working together on an idea where we're trying to bring together different experiences and different threads of expertise, in the sense that I'm an obstetrician and gynecologist, and yourself and Marie, who's the other key player, is a midwife, and a couple of my other colleagues being obstetricians, and that core group, I guess, and the related specialists, we see ourselves as an integrated maternity team that's able to put on the market a competitive end-to-end maternity program. And what sets it apart is that by design, the entry point is always through a midwife who does the psychosocial assessment using standardized tools and job aids, and then follows a fairly standard care pathway if there's no complications, because we're selecting the clients who are low risk, and then involving an obstetrician and a sonographer and midwife and other specialties on a timeline that's predictable, that becomes the care plan or the client journey for that patient, but also having the specialists in the background all the time. And I guess what holds the team together, the cohesive processes for the team, is really around what we call the multidisciplinary team meeting. This is a meeting where once a fortnight or once a week, depending on the volume of clients to be discussed, all the providers sit around the table and discuss the clinical and psychosocial aspects of clients that might impact or that might be impacted by their pregnancy. And that team then creates the pathway that everybody follows, working off the same clinical record and working off the same understanding that we always put the client in the center, and we always make decisions that are evidence-based and also cost-effective. So in that sense, what we put in the market is akin to a product that has got some entry criteria. So there are some clients who don't qualify for this program. And then it has stuff that you can carry on doing in the background, even when the client has been transferred to the specialists. The midwife is always going to be involved. So in a sense, I guess the long and short of our model is the team works together to serve a patient individually, and the team is coordinated by very specifically defined governance processes and operational processes. And I guess all that put together sets us apart in the South African context as Network One. I guess, Margaret, that kind of summarizes your question, and I hope our listeners have got a sense of what a team-based approach looks like, what we are trying to do ourselves in Johannesburg and in other cities where we're collaborating with obstetricians, and midwives. And I guess watch the space. Let's see where we get to. But thank you very much for the invite to speak. And I hope the rest of the event goes well. Thank you.
So thank you so much, Dr. Howard, for that very insightful conversation. I think it has brought a lot of clarity to many of our listeners' mind. And also, it's an absolute privilege to be working together and to see how we can improve midwife-led care together with obstetrician and gynae-led care for the right people to be on the right place. So that was us for today, and hope you enjoy that. Keep an eye out on our initiatives. We will be definitely making big boo-ha and news here on our platforms once we've gone more live. But we are testing it all out. So if you want to come be part of our initiative and our team and want to be seen, you can come visit us in Joburg and Woodmead. Look us up, network1health.co.za. That was us. Have a good one, and I'll see you for the next episode. Bye. Thank you so much for joining us today. If you enjoyed this video, please share this with a friend who will benefit from this. And remember to subscribe and hit the bell icon so that you can be notified whenever we release new videos like this on our channel. We'd love to stay in touch and keep you updated with all our latest content and resources to equip and empower you. So if you're a midwife or any type of birth and baby worker, go to sensitivemidwifery.co.za/free gift. If you're a mom, visit sisterlillian.co.za/free gift for more training and resources. That way we can keep you up to date when we release new episodes like this, plus a few other bonuses. You can also find the links I just mentioned in the show notes. Remember, you're making a big difference because you are shaping the future of humankind. Thanks for watching, and I look forward to journeying with you. Pregnancy is a time of great change and excitement, but it can also be a time of uncertainty. The Sister Lillian Center Essential Antenatal course will help you journey through your pregnancy better by arming you with the information you need to make informed choices about your health and well-being so you can have a healthy pregnancy experience and make the right choices for your birth. Click the link in the show notes or visit sisterlillian.co.za/pregnancy to find out more about this invaluable course. And hey, if you're enjoying the content, remember to share this with a fellow mommy or friend.